Disappointing is not the real conclusion, in my opinion. They were reaching the primary outcome of safety. So at the end of the day, this was the outcome. They were a little bit disappointing for the story of a heart failure, in terms that some signals were coming out, particularly for saxagliptin, that an increase of hospitalization for heart failure could be caused by this drug. Then a warning also was coming out in the exam with the allogliptin. What the hospitalization for heart failure was not significant, but the trend was positive. A subgroup analysis showed that a paradox, that there was an increase of hospitalization for heart failure, but in the people without a previous heart failure. And finally, the TECOS was negative in terms that this problem, heart failure, did not appear, but also there are papers looking at the real-life data, also showing an increase of heart failure with sitagliptin. What is the truth? The recent position of the American Heart Association is that this could be a class effect in a very small part of the diabetic population, maybe at high risk to be decompensated for heart failure, to be prone to heart failure. So I cannot say that really the results are disappointing. Let's say that they are as expected. This class is safe. Maybe we have to pay a little bit attention when the patients could be more prone to heart failure. But this is something that is also equivalent present for other drugs. I will conclude to say that a recent overview from the Ministry of Health of Italy show that there is an increase of risk for heart failure higher if you use sulfonylureas than if you use DPP-4 inhibitors. So at the end of the day, sulfonylureas are widely used. Nobody pays attention why to be worried about DPP-4 inhibitors. Of course, this, you know that the GLP-1 by itself has a lot of cardiovascular effects. There are tons of papers showing this. In the case of liraglutide specifically, in my opinion, it's not clear. Still not clear. Why? Because the effect was mainly in reducing cardiac death. No effect on myocardial infarction, effect on heart failure, stroke, and so on. But this kind of effect is usually related to an action on the progression of atherosclerosis, but the study is too short for this. One hypothesis is that, according to our studies, when you have a GLP-1 receptor analogs in the circulation, the cardiovascular system is more protected against extreme situations like acute hyperglycemia and acute hypoglycemia. Meaning that if you have this compound in the circulation, when something like this happens, you have more chance to be protected against an acute event. Of course, we need more studies, mechanistic study, to understand really the meaning of these results. There are two considerations. One is that the population in the study with the lixisenatide is different from the population of the lead study. In this the study, the ELIXIR study, people were at high risk for cardiovascular problems. The inclusion criteria was to have had an acute events in the last 6 months, if I remember, but anyhow in a very short time. So this is high risk population, so less chance to be positive. On the other hand, I have to say that Lix is a short-acting product, and it's not clear why it was positioning as long-acting, because it's given once a day. My personal point of view is that to have an action over the drug, you need the drug in the circulation. If the half-life is short, the risk is to not get the protective effect, and probably this contributes to the neutral result of the elixir.